Okay, looks like we've got everybody here. So we'll go ahead and call the meeting to order and me for the Pledge of Allegiance.
Is that too loud? Should I shut this door? No, it's fine.
I pledge allegiance
It's to the
to
flag
the flag of the United States of America
and to the
republic for which it
which
stands,
stands one nation under God, indivisible,
with
with
liberty
liberty
and
and
justice for all.
justice for all.
Okay, great. Dee, if you could call the roll.
Director Nicholson,
Present.
Director Yee,
Present.
Director Stewart,
Present.
Director Eapen,
Present.
Director Wallace.
Present.
Great. Dee, if you could tell us who else is in the room with you there.
I have Kimberly Hartz, Chris Henry, Larry Labossiere, Shri Bodu, Maria Nunes, and me, Dee Antonio.
Okay, great. Great. Thank you. Well, welcome to the July 14th, 2021 regular meeting of the Washington Township Healthcare District Board of Directors. In accordance with Governor Newsom's reopening plan for California and Executive Order N 2920, we will continue to conduct our meetings remotely while we develop plans to return to in-person meetings and develop hybrid formats that maintain Brown Act compliance while also providing greater accessibility and transparency to the public. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. Tonight's meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. We'll now move to the communications segment of our agenda. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Hearing none, do we have any written communications?
We do not.
Very good. So we'll now move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Hearing none. Does any member of the public want to remove an agenda item from the consent calendar? Hearing none, may I have a motion to approve the consent calendar item A?
In accordance with the district law, policies and procedures, I move that the Board of Directors approve the consent calendar item A.
Thank you. Do we have a second?
I'll second.
Second from Director Yee. Dee, if you could call a roll call vote.
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Eapen,
Aye.
Director Wallace.
Aye.
Great, thank you. The consent calendar action items are approved. So let's move on to our education session. And Kimberly, if you could introduce our speaker.
Yes, it's my pleasure to introduce Dr. Jack Rose. He joined Washington Township Medical Foundation in early 2014. Dr. Rose received his undergraduate degree from Stanford University and his medical degree from Columbia University's College of Physicians and Surgeons. Dr. Rose received his medical and neurological training at New York Presbyterian Hospital's Neurological Institute, where he was selected as chief resident. He did a 2-year neurocritical care and stroke fellowship at the University of California, San Francisco. Dr. Rose is an expert in neurointensive care and cerebrovascular disease and was among the first 100 physicians in the world to become board certified in neurocritical care. He is also board certified in neurology as well as vascular neurology. Dr. Rose's experience and leadership augments Washington Hospital's comprehensive stroke and neurosurgical programs, especially in cerebral vascular neurosurgery and interventional neuroradiology. He personally provides the patients treated at Washington Hospital with the continuity of care that is critical when treating the full range of cerebral vascular conditions. Dr. Rose is co-medical director of the stroke program with Dr. Prabhat Khalsa. He is also chair of Washington Hospital's Continuing Medical Education Committee and its Institutional Review Board. This evening, we also have Maria Nunes here. She is the clinical manager of the stroke program. And so this evening, Dr. Rose will be providing presenting the stroke program, the calendar year 2020 in review.
Thank you very much, Ms. Hartz. Can everybody hear me?
Yes.
Great. Shall I share my screen with the presentation so that I can advance it, or let's see if that works.
Yeah, do you want?
Dr. Rose, anything is fine.
Yeah.
Okay.
We see it fine.
Okay. Okay, can you guys see the presentation?
Yes.
Yes.
All right. Well, thank you again, Ms. Hartz, for that nice introduction and for, again, allowing me to present our year in review for our stroke program and quality report. And if you have questions during or afterwards, I'd be happy to answer any questions. I have to start by acknowledging the outstanding leadership of our outgoing CNO and VP, Stephanie Williams, who was tasked with overseeing our stroke program for many years, by Nancy Farber and now Kimberly Hartz, and has done a tremendous job over the last several years. And it was a privilege to work with her, and we wish her all the best in her retirement. Like Ms. Hartz mentioned, Dr. Khalsa and I are the co-medical directors of our stroke program, and we have 4 neurologists on our team, Dr. Singh, Dr. Khalsa, myself, and Dr. Kalon. Michael Platzbecker has been our stroke program director for the last couple of years, and Maria Nunez, who is in the boardroom that you can see, is our clinical manager of the stroke program and is a nurse practitioner as well. We, like many of you already know, we have a very unique program here at Washington Hospital. We're one of the few places in the world that have 24-hour stroke nurses. And many of our stroke nurses have advanced degrees in stroke or other advanced nursing practice. And they are sort of a key backbone of our program and its successes. We obviously have stroke neurologists, general neurologists. I am a neurointensivist. We have a team of neurosurgeons and interventional neurosurgeons and interventional radiologists to help treat our complex vascular neurology patients. And our program is led by a stroke coordinator with a nurse practitioner certification. It's not just the doctors and the nurses that are involved in our very patient-centered, patient-first ethic stroke care. It's a whole team of doctors and allied health professionals who are involved in taking care of our patients. You see the patient at the center here, surrounded by a whole team of other bubbles, starting with outside of the hospital, EMS 911 activation brings patients to us frequently, who are rapidly seen by our emergency department doctors and nurses. Our stroke nurses are available immediately to assess them during their emergency room visit. They work closely with pharmacists, radiologists, technologists, neurologists, and when they're admitted to the hospital, they have a whole team of additional physicians, nurses, rehabilitation experts, therapists, case managers, social workers, et cetera. It goes on. And we very much appreciate the good collaboration and coordinate communication we have between all of these different team members in order to provide the best care for our patients. And we don't just focus on providing the latest stroke care, but in a very timely and compassionate fashion. In terms of our programmatic guidance and how we disseminate our data about our program and how well we're doing and what we can do to improve. We have a monthly stroke review committee meeting that is run by Maria Nunez, as well as Dr. Kalsa and myself. We include participants from our emergency department, from our radiology department. All the neurologists attend. We also have representatives from administration there and a hospitalist group. We also have, I'm part of the critical care committee meeting, which we sometimes discuss issues related to our stroke patients. And we have an annual presentation of our program and our data to the board of directors, as well as to all our quality steering committee, which is occurring next month. How has our stroke program patient volume been doing over the last year? Well, if you look at the right side of this graph here, you see that the volume of our stroke patients, that includes both blocked artery strokes, which are the majority of our stroke patients, but also bleeding stroke patients. You'll see that our volume was about 441 patients, which is similar to years past, actually, although slightly down from 2019. And we did see a brief decrease in the number of patients coming to our hospital for stroke in the beginning of the pandemic. People were afraid for a short period of time to come to the hospital, and stroke is one of those diseases that we never want patients to neglect going to medical attention. And so we worked very hard to get the message out to the community that you should not wait at home or be afraid to come to the hospital if you have any signs or symptoms of stroke, and that we're well prepared to take good and safe care of our patients. And so in the end, after the whole 2020, our stroke volume has been similar. So we were impressed that our stroke volume stayed relatively steady despite the pandemic. In terms of our advanced neuroradiology services that we were able to provide in 2020, this left column here are our volume of thrombectomies. That's the name for a procedure that's used where a surgeon or a radiologist puts a tiny catheter through a groin artery all the way up to a blocked brain artery and removes a blood clot that's causing a stroke directly by capturing it with a device and removing it from the body. We did that about 6 times in 2020. And this year, even though we've only had 6 months in the year, we already have done that 5 times. So we're on par to do that about 10 times this year. So our volume for thrombectomies is going up. Clipping and coiling volume refers to the number of patients that we treat with ruptured brain aneurysms or unruptured brain aneurysms through either a minimally invasive surgical procedure where metal coils are put into an aneurysm, or an open surgical clipping procedure. And we had a dozen of those in 2020. Carotid stents are a procedure that's used to open up a narrowed neck artery to protect someone against stroke. We only did 1 of those last year, and that's because this procedure has been shown not to be better than traditional open vascular surgical procedures to treat narrowed neck arteries. And there's a clinical trial that's ongoing to see whether this should even be done in the absence of concerning brain symptoms in patients with neck narrowed arteries. And we're fortunate to be one of the sites for this landmark clinical trial. And so that's why the number of carotid stents are down. It's not that we could not find enough patients or did not have the ability to do this procedure. This procedure is not as indicated as it used to be in the past. How are we doing in terms of our outcomes? How well are our patients doing after coming to us with stroke or after we diagnose them with a stroke? Well, one of the ways that we look at our outcomes is we look at key quality measures that are required to be reported to the American Stroke Association, American Heart Association. There's a program called Get With The Guidelines, and this is a method to make sure that stroke centers are in compliance with key quality measures that are known to be markers of good, high quality stroke care. And you see here are these 10 performance measures that we track on an ongoing basis. And these include a variety of clinical and non-clinical performance measures, like do we provide appropriate education to our patients and their families? Do we give them a clot-breaking medicine rapidly when appropriate? Do we give them certain blood thinner medicines in a certain time frame after presenting to us in stroke? Do we give them a blood thinner if they have atrial fibrillation? Do we give them a statin medication discharge to lower their cholesterol level? Do we talk to them about smoking cessation if they smoke? Do we assess them for rehabilitation needs, et cetera? And you see that of all these 10 markers, we have been 100% compliant with 9 of these 10 measures. The one that we fell slightly short of 100% compliance with is discharge on an intensive level of a statin medication. And I want to mention that this is a new performance measure. It used to be just statin at discharge, but recently, within the last year or two, the performance measure was changed to require an intensive level dose of a statin medicine. And so we've been working hard to improve that level from 94% to 100%, although the target is greater than 85%. So we're definitely above the 85% goal, but we'd like to get this up to 100% as well. And how are we doing this? Well, we sent out a communication to the entire medical staff, explaining to them this new guideline about intensive statin discharge of patients with stroke or TIA. And we also have, we started having a best practice advisory. That's a banner that flashes to the discharging physician at the time of discharge to remind them that their patient was diagnosed with stroke or TIA and that therefore they should be discharged on an intensive level statin unless contraindicated. So we are hoping that these measures will significantly improve our compliance with this, although we do a pretty good job already. And you can break each of these individual guidelines down over time and look at it to see how well we've been doing. This is just one example of how well we've been doing with discharging patients on blood thinners, a particular kind of anticoagulant blood thinner if they have atrial fibrillation or flutter. And you see that over the last 5 to 6 years, we've been nearly or at 100%, well above the 85% target. What about our functional outcomes? How well are our patients able to function when they're discharged from the hospital after being diagnosed from a stroke? Well, if you consider the key disability scale that we use to rate patients' disability after stroke, it's called the Rankin scale, and a score of 0 to 3 out of a 6-point scale indicates either no or mild disability, and 0 to 3 is considered a good functional outcome. 4 to 6 is considered a bad functional outcome. And if you look at the breakdown of good versus worse outcome at discharge, the green pie part of the pie here is 60% of our patients are discharged from our hospital with a good clinical functional status, compared to all the other California hospitals reporting only 27%. So we do a very good job of at least discharging our patients in a good functional state compared to other hospitals. And this is a finding that has been consistent for the last few years. Other key performance measures that we're proud to report. One of our goals is to identify stroke patients that qualify for acute administration of an intravenous IV blood thinner medicine, a medicine to dissolve blood clots. It's called TPA. It's the one acute stroke treatment therapy that we have that we can provide within the first 3.5 to 4.5 hours of stroke symptoms. And the goal has always been to try to get it to patients appropriately and safety in as fast a period of time as possible. And in 2020, the stroke organizations set the goal of 75% of the patients to receive this clot buster medicine TPA within 60 minutes of presenting to the emergency department. And in the past, we've been able to do that fairly well, but in 2018, we were only just at that 75% rate of getting that clot busting medicine to patients within an hour of presentation. But in the last 2 years, we improved that to 91% to 96% in 2020. So we're very happy. How did we improve that over the last couple of years? Well, a couple of ways. One of the ways was that we leveraged and used technology to be able to have an iPad available to video conference the neurologists and any other physicians that might want to rapidly assess the patients to confirm the diagnosis and to guide therapy together with the ER staff and the stroke nurses. And we also work very carefully with our stroke nurses and ED staff to rapidly throughput our patients in the emergency department to quickly get evaluated, scanned, and given this medicine if it's indicated. And so we're happy to report continued improvement within 60 minutes. And we're not, and if you compare our percentage of patients that get this clot-busting medicine within 60 minutes to other hospitals, in 2019, that's the bottom two bars here, all certified primary stroke centers like we are red. A little bit more than 80% of the hospitals were able to, other hospitals were able to get the drug within an hour to patients, whereas we were over 90% in 2019. And then in 2020, the green bar is us. We're in the high 90%, and all other primary stroke centers only a little bit more than 80%. So we're continue to do better than most certified stroke centers in terms of our percentage of patients getting this life-sparing and function-saving medicine within an hour. We also look at whether we can get this quickly to people within 45 minutes of showing up to our door, and with the goal by the major organizations to try to achieve 50% of your patients to get this clot-busting medicine within 45 minutes of presentation. And we were able to surpass that to 64% in the last year. The prior 2 years, we were a little bit under that 50% goal. And so we were very happy to improve this within the last year. And again, how did we do this? By, again, leveraging technology and having continuous quality measures and quality improvement with working with our ED staff and our stroke nurses to more rapidly triage patients and assess them for TPA clot-busting medicine. So we were very happy to see that improvement. And again, where we, in 2019, we did not perform better than other primary stroke center hospitals in terms of how often we can get this clot-busting medicine to patients within 45 minutes. But in 2020, we did better than all other primary stroke center hospitals. So that was a significant improvement within the last year. And another key to how we're able to do this so rapidly is we have a code neuro process that many of you who work in the hospital here recognize. This is an overhead code called for possible stroke patients that show up to our ER. There's an overhead page identifying a patient with possible acute stroke, which rapidly gets them to ER MD evaluation, rapid brain scanning, rapid blood tests, and rapid assessment by our stroke nurse neurologist to see if they can get this and or other acute therapies. And this works very, very effectively to help rapidly identify our stroke patients and treat them appropriately. This is a chart showing in 2019, we were able to get a CT scan, a brain picture test read by our radiologist within 45 minutes of arrival, about a little more than 93% of the time, which is similar to all California hospitals. In 2020, we were able to do a little bit better, or again, similar to other hospitals. It was slightly less, about 88% of the time. We were able to do that within 45 minutes. And I think this slight decrease that you see, not just at our hospital, but in all hospitals, is because of COVID. Some of the delays required in terms of keeping patients and staff safe, that led to a little bit of delay in throughput in the ER. So I think that's why there was a minor tick. But again, this is not isolated to Washington Hospital, and a minor decrease. And in terms of physician assessment within 15 minutes, in 2019, we were doing better than most hospitals, 84% of the time, getting an ER physician to see a possible stroke patient within 15 minutes. Whereas in 2020, we dropped a little bit and are now similar to the other hospitals. And again, this is all potential stroke. These are all stroke patients that show up, whether they come in via ambulance or if they walk in to our emergency department. Sometimes it's challenging if a patient walks in with vague symptoms that end up having a stroke. Sometimes they may not be seen by an ER physician within 15 minutes. But still, almost 3/4 of the time, they are seen very, very rapidly by our ER doctors, similar to other hospitals. And then rapid blood testing is crucial, especially in terms of safety of giving them TPA, this blood clot busting medication. One of the key blood tests that we have to do immediately is a blood sugar level, and in 2019, we were able to do rapid point of care testing for blood sugar almost 100% of the time, whereas other hospitals, less than that, 60% of the time, would have to wait for a slower blood glucose level to show up. And we had similar 95% success at getting that rapid blood sugar level measured in our hospital, better than other hospitals that are report to get with the guidelines. What about the percent? How are our patients with strokes coming to our hospital? We track this because it's important, and we always want to educate the public to try to identify stroke symptoms rapidly and present to the hospital via 911, via EMS, not try to drive themselves or have their family drive themselves to the hospital because it speeds up their care and it's safer. In the past, we had in 2018, 54% of our patients showed up to our emergency room with stroke via EMS, compared to 44% were walk-ins. And with our educational activities, we were able to improve that in 2019 to 63%. But in 2020, we did see a decrease in the percentage of patients showing up to us via 911. It went back to about 50%. And this, we think, is directly related to the fear that was there associated with COVID. And so we're continuing our efforts to educate the public about to please use 911 and get to the hospital via EMS, not private vehicle, and that it's safe to do so, even while we're still in the tail end of this pandemic. So nothing very concerning about that, but we did notice this trend, and we continue to have about 1% to 2% of our stroke patients volume coming from outside hospitals. So the vast majority of our stroke patients that you're seeing the data from are from our own emergency department. How are our mortality? What is our mortalities like? What is how often do our patients die when they come to us with stroke? And if you compare that to other California hospitals that report their data to the Get With The Guidelines, that are either primary stroke centers like we are, or primary or comprehensive stroke centers. This is a chart looking in the past 5 years, looking at risk-adjusted mortality of all of our strokes. So this is a global risk, both blocked artery strokes and bleeding strokes. And our hospital is the green line here. So you see our risk-adjusted mortality rate is 1.2 compared to all other primary stroke centers, which is a similar level of stroke center that we are, is a little bit higher than that. And compared to all hospitals, and that includes comprehensive stroke centers as well, yet higher than that. And that's been a consistent finding, that we do a little bit better in terms of overall risk-adjusted global stroke mortality. So we're happy to see that, and are continuing to track this. And we review all the deaths of our patients on a monthly basis in our stroke review committee. And we of the patients that end up dying, we almost always see them to have been patients that have presented with us with the most severe strokes. And it's very rare for us to have an unexpected death. But stroke is a very deadly disease, still the 5th leading cause of death in the United States. What about staff education? We spend a lot of time to educate our staff about stroke, the latest advances in stroke care, and our own outcomes and processes and procedures. Dr. Carlson and I give a bi-monthly neurovascular case series. In fact, I just presented one a couple hours ago, where every month we review 3 interesting cases with other doctors, nurses, anyone who wants to come listen to our stroke cases. And we continue to do this on Zoom when we can no longer meet in public. And it's a very well-attended conference, and we provide continuing education for doctors and nurses to attend as well. So it's a very successful educational activity that we provide. We also have our stroke review committee meeting to go over educational topics. Like I mentioned, we occasionally have a grand rounds on a neuro topic. We have Critical Care Skills Day that includes a neuro presentation, last held in 2019. We have frequent emergency department nurses huddles with the stroke nurses and their other emergency room nurses, and we do code neuro simulations, especially for our new onboarding stroke nurses. That's in terms of staff education. What about patient education? We work very diligently to provide stroke education to all of our patients and their families and caregivers, both in person and virtually. It's good that now we're able to at least have some family members come to the hospital, but we very much like to do one-on-one education with our stroke nurses and the patients and their families, talk to them about rehab, secondary stroke prevention measures. Our pharmacy team does an excellent job of reviewing medications prior to discharge, and we always individualize our stroke plan of care with our patients and hand them paper information, not just go over that verbally, so that they know why they had a stroke and what they can do in the future to prevent themselves and their loved ones and friends and family to avoid stroke as well. What about beyond our stroke patients and our staff? In terms of community education, we continue to collaborate with our local EMS providers. We had a stroke alert day that we participated in this past year, despite the pandemic. We have quarterly meetings with EMS. We submit data on a quarterly basis, and mostly in terms of our stroke volume, percentage of patients that come in via EMS versus walk-ins, what our numbers are, and work to provide some latest clinical information to our EMS providers as we can. We also provide a stroke support group for survivors of stroke or family members of stroke survivors. And we used to have this on a monthly basis in person. With COVID, we had to cancel these inpatient stroke support groups, but recently we've resumed that via Zoom. Some of our patients are a little bit elderly and might have difficulty with this, and so we've provided training sessions for them so that they can leverage our technology to continue to have stroke support groups. We also have other community outreach events that we sponsor and or co-sponsor. We have educational series that we provide stroke awareness day education. We last did that in 2019. We do blood pressure, carotid stenosis screening, other stroke prevention screening measures during some of these awareness days. We have community outreach series that we co-sponsor, like Concert in the Park, and a stroke event at the Fremont BART. Again, canceled this past year because of COVID, but we hope to do that again in the future. We also use our own cable TV network to focus on information about health, about stroke and stroke prevention. And Maria, our stroke program coordinator, gave a presentation to a women's group, a Spanish-speaking women's group in Newark, using a translator to educate them about stroke and stroke prevention and treatment. And we also had an article about our stroke program in the Tri-City newspaper within the past year. How about our achievements in 2019 to 2020? We received the Get With the Guidelines Gold Plus Elite Award, as well as a newer award for excellent in diabetes care. And that's important because diabetes is a key risk factor for stroke. We performed very well in terms of our percentages of the times we were able to give that clot-busting medicine within 45 to 60 minutes, like I showed you earlier. We received the hospital's first Interprofessional Team Excellence Award. I'll show you the picture for that in a minute. We acquired a new neuroimaging software called Rapid, which has really helped our rapid imaging results and facilitated our good outcomes and rapid diagnosis of stroke patients. And we're very appreciative to have this software. It identify patients that could qualify for thrombectomies. So we're very successful implementation of that. So thank you to the administration and the radiology group for obtaining that. And it's been a really excellent piece of technology we've been able to benefit from. We also are many members of our stroke team attended a recent Pacific Stroke Association conference. And like I mentioned earlier, we are participating in a pivotal carotid neck artery stenosis trial called CREST-2, which is looking at what the best treatment is, medicine versus surgery for patients that have asymptomatic narrowing of neck arteries, about whether to just use medicines or to use some kind of surgical procedure to open up narrowed neck brain arteries. What about within the last year, 2020 to 2021, we again received the Gold Plus Elite Award from Get With The Guidelines and the Target Honor Roll for Diabetes. We've been able to increase the number of thrombectomy cases. That's using a device to pull out a blood clot from a brain artery. And we added an additional neurointerventional specialist, Dr. David Carrington, who is a neurointerventional radiologist, so that we now have 365 days of the year, 24/7 capabilities to treat a patient with stroke. And since Dr. Carrington came aboard, we have not transferred a patient out to Stanford or UCSF for such a procedure, which we occasionally rarely had to do in the past. So we're very happy to have added neurointerventional coverage with Dr. Carrington on the team. We also are excited about expanding our services in stroke to other areas, which we have not yet received transfer patients. So the San Joaquin Valley is one area we've identified to augment our volume and to partner with. And we are using our marketing strategy development for the entire neuroscience program to help our stroke program as well. So we're excited about that. This is the picture about our whole team receiving the Interprofessional Team Excellence Award, the first one for the hospital. And you see as a big team of doctors and nurses and other staff involved in the team here. And it was just a nice award to really show how we have interprofessional collaboration to provide an outstanding service, clinical service. What about our goals for the next year? We're working on trying to increase the percentage of patients that get our clot busting medicine not within half an hour, not within 45 minutes, but even hopefully within 30 minutes of hitting our emergency room door, which is very challenging because there's some risks associated with the medicine. You want to give it appropriately, but we're trying to at least give this clot busting medicine within 30 minutes to a number of patients if we can do it safely. We're also focusing on increasing the number of patients that get this advanced surgical procedure to treat a large blocked artery. Now, for certain patients that have a blocked large artery in their brain, we can do this procedure sometimes up to 24 hours after the stroke has occurred. Not in most patients, but in some. And so we're using this latest clinical data to try to increase the number of patients that can get this successful surgery. And with that, we're also looking to apply for advanced Joint Commission certification, a new level of certification called thrombectomy capable. We are a thrombectomy capable center, but we want to become a certified thrombectomy capable stroke center. And so we're working towards applying for that within the next couple of years. Long-term goal to become an official certified comprehensive stroke center as well. And we also, like I mentioned, are continuing to market to try to improve our outreach to other counties to bring in patients to our stroke program, because we think we do a very good job of taking care of stroke patients here at Washington. And again, lastly, we want to have this message out to our entire community that we're very well equipped, despite the pandemic, to treat stroke patients carefully and safely with very high quality, and that we have stringent safety protocols that we want to make sure that the community knows about, and that time is brain, to not delay your care if you potentially having stroke symptoms or signs, or you see somebody that has that, and to educate the community about knowing the signs of stroke, warning signs such as this be fast mnemonic. If you suddenly have trouble with your balance, if you suddenly have visual problems with your eyes, if you suddenly have a drooping face, if you suddenly can't move one of your arms very well, sudden speech impairment, these are signs of a stroke, warning sign of a stroke, and time is important to get to the hospital quickly, not try to self-diagnose or bring yourself to medical attention, to call 911 immediately. And we go over all this information, not just in educational outreach efforts and in education for our patients and their families, but on our website as well. If you want to see more information about our stroke program, you can visit our stroke program's website at wwhs.com/stroke. So that's the talk. Thank you very much for your time. I'd be happy to answer any questions.
Great. Thank you very much, Dr. Rose, for an excellent presentation. And thank you to you, to Dr. Kalsa, and especially to Maria for running an excellent stroke program here at Washington, which provides very fast treatment and provides excellent outcomes. And we have just such a great stroke team, all the stroke nurses. I'm so impressed with the number of code neuros that I hear when I'm in the hospital. So there's a lot of activity. So one question I had was last year when COVID was running a lot through our hospital and through our community, is many patients were reluctant to come to the hospital for treatment. Question for you is, did we see a increase in the delay from onset of symptoms to the time of presentation?
We definitely did, especially in the first few months of the pandemic. We not only saw a significant delay in terms of how long it took patients to come to the hospital, but we found that by the time that most of the patients came to us, they were very sick, on higher than average when we would expect in terms of all of our comers coming to us for stroke. So it seemed like people were delaying their care, and a higher percentage of patients were sicker than they might have been had they come earlier. So we saw increased percentage of severe stroke patients, and a large number of patients coming in, even if they weren't severe, that waited many, many days to present to us. So we did see that, unfortunately, and but we did see improvement in that. But that definitely happened.
Yeah, thank you. So it really underscores that time is brain when you're dealing with stroke.
Yeah.
Good. Any questions from our board members? Jeannie, Mike, Bernie, Jacob?
Thank you.
Jack, yeah, great presentation and great job. The only thing I wanted to ask you was, you did mention that there are other centers that have come up in our radius that are, stroke certified. Which are the ones that have come up in our neighborhood?
Well, in terms of advanced stroke certification, is that what you're asking?
Yeah, because you had mentioned in the slide that in spite of increased competition.
Right. Yeah, no, I think in terms of our stroke volume, even though there are more and more hospitals that are primary stroke center certified and even comprehensive or thrombectomy capable, we haven't seen a decrease in volume, which we're proud of. There are other hospitals like Stanford and UCSF that are at higher certification levels than we are, but we provide the same level of procedures and care and stroke quality that they do, but maybe at a lower volume. And that's why we haven't become sort of a higher level of certification yet. We're trying to augment our volume so that we can qualify for that certification. So we're an extremely highly functioning, high quality primary stroke center that functions just like any other comprehensive stroke center in the Bay Area, but we're not officially certified as such yet, and we're working towards that.
Okay, thanks.
Sure.
Any other questions? I have one. With the extension of the window to 24 hours for the large vessel obstruction, how big an increase do you see in our thrombectomy volume?
Well, we've seen an increase. The challenge is that only 10 to 15% of our stroke patients have a large vessel blockage to begin with, and then only a percentage of those have other features that suggest that a procedure would benefit them. So you're talking about 50% of 10 to 15% of the patients might even qualify for it. So even though the time window is extended, you have other conditions that need to be present in order for us to know that they might clinically benefit from the procedure. So it's not like we expect to see a massive increase in the number of thrombectomies, but we are able to provide that procedure to a higher percentage of patients than ever before. It's just that we still are not seeing as many patients that could qualify that would dramatically increase the number of procedures that we do. And part of that is also because that we have a lot better medical therapies that are protecting patients against large vessel occlusions than ever before. So as you know, we have much safer and effective blood thinners that can prevent AFib patients from having large artery blocked strokes, which we didn't necessarily have in the past. And so I think that while we expect to have an increased number of patients qualify for that procedure, it's not like we expect to see a doubling or a tripling of the volume. But it is definitely a very beneficial procedure to be able to do. And in the right circumstance, you can take somebody that's completely paralyzed and looking at a very, very severe bad outcome and really amazingly increase their long-term functional outcome within an hour or two. So it's a really dramatic procedure for the patients that it's useful for.
It's wonderful that we're able to provide data.
Yep, absolutely.
It's just delightful. Well, we hope to see a continued reduction in stroke patients, better prevention as we get better care of diabetes and hypertension, hyperlipidemia, all of those
yes,
things.
absolutely.
But I'm so appreciative to the stroke team that they have such a high level of functioning and excellent outcomes. So thank you to all of you for your great work.
All right. Well, thank you for all your support.
Yeah.
Okay. So we'll now move on to our medical staff report with our new Chief of Staff. Dr. Hyder, this is your first time before us as Chief of Staff rather than Chief of Staff-elect. So welcome.
Good evening and welcome to all and respected board members, my community and public. So I took over, I'm Shakir Haider, I'm a gastroenterologist and hepatologist. I took over from Dr. Prasad Kalaru, the former Chief of Staff, who served in 8 years, I would like to recognize him for his exemplary service tenure in a tough, and it is very tough to follow him. And the other thing is I took over from Dr. Prasad, and I would like to also thank Dr. Achanta, who served for 8 years in the medical staff and leadership. And he did a very remarkable service to the medical staff and to the hospital. And after stating that, we have Dr. Tim Choi as our new chief from the Chief of Staff. He was ex, and now he's a medical liaison officer. And Dr. Mark Saleh, the Chief of Staff elect. And I would like to give a special thanks to recognize Dr. Stewart for his excellent leadership in service and commitment. So we have an active staff of 357 with administrative 1, allied health 35, ambulatory 95, consulting 9, courtesy 23, provisional 63, leave of absence 2, comes to total of 585. And we have some new department chair. Anesthesiology is Dr. Berry, and pediatrics is Dr. Pila, medicine is Dr. Zizarad, and surgery is Dr. Nod. Radiology is Dr. Opender, and family medicine is Dr. Nivan, and OB-GYN is Dr. Pila Sharma. After stating that, I would like to even tell that our hospital and community was greatly tested this past year in the face of pandemic and novel virus that had never been seen before. During the difficult time, our community stepped up to plate and faced the crisis head on. We have proven our great and unwavering commitment to patients. Now we are finally seeing a light at the end of the tunnel. We have so many people to thank for helping our community get through this challenge. First of all, I would like to thank the community and all our patients. You are the reason we show up every day. We relied on your resilience to get us through the crisis together. You stayed home when we asked you to and did your part in stopping the spread. As you know, our board members are publicly elected and have proven commitment to making the mission of this hospital successful. I would like to recognize all the board members. A year and a half ago, the world has no idea that a deadly disease would spread around the world and truly test what it means to practice medicine. The medical staff at Washington Hospital have truly proven to be heroes. You gave it all you got. We thank you for the remaining laser focus, drawing all your inner strength and showing up each day to care for the patients. And above all, I thank Ms. Kimberly Hartz for her excellent, guidance and leadership. She performed the exemplary job during the unprecedented curveball, and I don't think anybody could do like that. I thank you very much, Ms. Hartz. The other thing is I would like all the board members also to attend the dinner dance, annual dinner dance on the 7th of August. And we are going to honor Dr. Mahigan for his exemplary service for a long time in our hospital. Thank you so much.
Well, thank you, Dr. Hyder, for your report and especially for your kind words of appreciation to the community and the hospital community for all that we've gone through and struggled with this past year. As you know, we could not have done it without the highest level of medical staff leadership. And so we appreciate all that the medical staff leaders have done, and we have a great deal of confidence in the medical staff leadership. I know Dr. Kilaru has set a very high bar, and he's forged a good pathway to follow. So we look forward to a great year ahead, and hopefully one which is not so difficult as we've had this past.
It's definitely certainly a tough thing to follow. It's strong.
Well, I've got my dancing shoes polished so that we can join you at the dinner dance on the 7th. Now, I haven't had much practice, but we'll do our best.
Thank you so much.
I hope the rest of the board will join.
Thank you so much, Nikhil. Thank you so much.
Thank you very much, Dr.
Thank you.
Okay, we've got our Service League report with Sheila Vijay. So Sheila, where is Debbie? What happened to our fearless leader, Debbie? Oh, you're muted. Gotta unmute. Sheila, you're muted. Unmute.
Sheila, can you unmute? You need to unmute.
Sorry.
There you go.
Okay.
I'm so nervous I forgot to unmute myself. I apologize.
Well, and why don't Sheila, Sheila, why don't I give just a little introduction about you too? Yeah, so Sheila Vijay is the first vice president of the Washington Hospital Service League. She has been volunteering since 2019. She has volunteered and trained many volunteers in staffing assignments, including nursing unit assist, infusion center, pharmacy, COVID-19 vaccine, and vaccine syringe labeling. She has volunteered at Kaiser Permanente as well. Prior to volunteering at Washington, Sheila was the principal of a private school in San Jose for more than 8 years, where she managed over 900 students and over 100 employees. So thank you this evening, Sheila, for stepping in for Debbie and giving us the report.
Thank you very much for that introduction, Ms. Hartz. I really appreciate that. And thank you also to all the board members for having me this evening. I am so sorry to disappoint you that Debbie is not here. I was asking Dr. Nicholson if I should put a picture here of Debbie's face so you'd feel more comfortable. You'd feel like you're hearing from her. Well, I don't have a picture, Dr. Nicholson, so I'm sorry. Well, before I present my report, I would like to convey on behalf of all the Service League members how warmly they have been received by the hospital clinical staff, by the nurses and the doctors. And I would also like to give you all a very short sneak peek of my experience on my first day back to volunteering after COVID. I'm not going to say after COVID because it's still happening, I guess, but it is post-COVID. So pre-COVID, none of us thought, the volunteers thought, what we really meant to the hospital. That was including me. We walked in, we volunteered, we went back home, and we didn't know how important we were to the hospital until recently we opened the telemetry unit and I walked in to volunteer. I was 200% sure that I would remember the doctors and the nurses, but I wasn't too sure if they would remember me. I had my mask on, I had my face shield on. It had been more than a year. And who would remember volunteers? We come in there, we are there for a couple of hours, 3 hours, once or twice a week, or maybe twice a month, and we go back home. So I wasn't too sure. The first thing we do when we walk in is check in at the nurses station. That's what I did. I walk in to check in at the nurses station. Couple of nurses were working on their computer, and the head nurse was there. I guess it was a quiet day that day, and the CNA was walking by. I could not believe what happened. They just all stopped what they were doing because I had my burgundy volunteer shirt on. They literally stopped and said, "Oh my God, you're back?" And then very doubtfully said, "Are you back?" Because they were still not sure. It was too good to be believed. And as I answered, I said, "Yes, we are coming back. You are the chosen one. The telemetry unit is the first one to be opened." They expressed how thankful they were to have us back, how much they had missed us. It was really overwhelming. It was very overwhelming to be received so warmly, feel so important, so wanted by the nurses. It was by far the best welcome I have received in my entire life. I have never felt so important. Not even my husband has made me feel so important. That's how important I felt that day. This is just a very small sneak peek as to how much we mean to the hospital. And this is just one simple incident that I thought I should convey on behalf of the Service League members. It's not just me, but most of us have had countless such experiences, and it's just been wonderful to be back. And again, on behalf of the Service League members, I do want to thank the hospital, and it's just wonderful to be back in service again. So I'm now going back to my report, and as I promised, I would keep the story short. So that was a short one. So here I am with my report from the Service League report from Debbie Fieri, the president. The hours worked in the past month: 69 members of the Service League volunteered 947 hours. The numbers obviously has gone up significantly because we have opened up more staffing assignment. At this time, the volunteering is only open to adult and college age volunteers, high schoolers. Hopefully, we wait to welcome them, hopefully in the fall. To date, the volunteers have assembled more than 16,000 COVID test kits, and we are still doing that. In fact, Ruth was assembling with a couple of volunteers today, so we are continuing to do that. We have also labeled over 35,000 vaccination syringes for the pharmacy. That's, again, we are continuing to do that as and when needed. Volunteers have also returned to a number of pre-existing assignments. In the surgical waiting area, surgical liaisons are supporting family members. 16 volunteers are being trained each week in the nurses unit, in the telemetry unit. In the imaging center, a volunteer is now greeting patients and family members each week. And it's exciting to watch those four-legged creatures, the wolf canine therapy teams, walking around now, visiting the patient in the oncology unit. So that's been wonderful. Overall, the reintroduction of the volunteers to the hospital has gone very, very smoothly, thanks to all of you and all the hospital, and of course all the volunteers who have been coming back. And we look to expanding the number of clinical areas to where volunteers can come in and serve. They just can't wait to come back, and we just hope we open it sooner, and we'll see more of them walking around. Thank you very much.
Well, thank you, Sheila. You can't really understand how glad we are to have you back. And you've seen a glimpse of how much the Service League is appreciated by all the staff members and the patients of the hospital. So great to see you back. Great work with the vaccine clinic and the thousands and thousands of vaccinations that you assisted with. That was such wonderful work.
Thank you very much, Dr. Nicholson. As they say, absence makes the heart grow fonder. And I think that COVID has brought that situation. The hospital has become that much more important to us volunteers, and we are very happy to be back. Thank you very much.
Wonderful. Thank you. Thank you so much, Sheila. And give my best to Debbie.
Absolutely. And sir, she will be back next time, I'm pretty sure.
All right. Okay. Thank you.
Thank you.
Good. Okay. So we'll now move on to our finance report, which is going to be given by Chris Henry.
Yeah, thank you, Dr. Nicholson. Tonight, we'll be looking at Washington Hospital's operating and financial results for this last May. Looking at our acute inpatient statistics, our average daily census for the month was 12.4 below budget at 130.4. Admissions for the month came in at 744 against a budget of 913. And those admissions resulted in 4,042 patient days. That was about 385 days fewer than we expected in the budget. Outpatient observation equivalent days, however, were 129 above budget at 312 for the month, and our average length of stay based on discharges came in at 5.11 against a budget of 4.85. Looking at utilization, case mix index for the month remains high at 1.641. We had expected 1.477 in the budget. So the patients that are coming are a lot sicker than what we've seen in the past. Deliveries for the month came in 12 below budget at 119. We had 343 surgical cases in May against a budget of 381. Also lower than budget were our cath lab procedures that came in at 298 against a budget of 383. Cath lab, we did have one of our physicians that was out for a couple of weeks, I believe, and that was the big driver on the cath lab volume. Outpatient visits for the month were 205 below budget at 7,464, but that's significantly higher than our 12-month average. That was 7,058. Likewise, our emergency room visits were 362 lower than budget at 3,812, but again higher than our 6-month average or our 12-month average. That was 3,527. So those volumes are starting to creep up. Of course, we had no RSTU visits in the month as that unit was closed. Looking at the details of surgical and cath lab activity, joint replacement cases for the month were 26 lower than budget at 143. Also, neurosurgical cases and general surgical cases came in lower than budget. Cardiac surgical cases, on the contrary, were 4 above budget at 13. In the cath lab, really, most of the product lines, or actually all of the product lines, lower than budget, as you can see there. Looking at productivity, our productive FTEs for the month were 4.6 higher than budget at 1,279.9. We had 149.7 non-productive FTEs in May, giving us total FTEs that were 6 above budget at 1,429.6. And our FTEs per AOB came in a little higher than we would have liked to have seen at 6.39, but not too bad. Moving into the financials, and as always, we'll look at our Governmental Accounting Standards Board presentation. This is the presentation that we use for our audited financials. Total patient revenue in May came in almost $6.6 million below the budget at $170,684,000. However, our contractuals came in a little bit lower than we expected at 76.58%. Take a quick look at that. We continued to evaluate our contractuals as we're coming into year end. We did bring them down about $1.8 million in the month, and that should probably pretty much do it as we go into June. So our contractual allowance actually came in lower than budget by almost $6.3 million, or 74.83% of gross revenue. Our provision for bad debt came in a little bit lower than budget at 1.75% of gross revenue. And again, our total deductions from revenue a little bit lower than expected in the budget, consistent with the lower revenue. Operating expenses, so we ended up the month with net revenue a little bit less than $800,000 higher than budget at $40,804,000 with our lower contractuals. Operating expenses for the month came in almost $2.4 million below budget at $37,770,000. Had a number of things really driving that difference. Salaries and wages with our higher FTEs actually came in $447,000 higher than budget. We did have less ETO taken in the month than we had anticipated. Going the other direction, benefits were just short of $1.4 million lower than budget. We had a number of things going on in there. Our Blue Shield claims were $565,000 lower than budget. And we also had a $576,000 stop loss recovery on some high dollar claims that had been going on during the year. We had a pickup, a reduction in our post-retirement benefit liability as a result of our actuarial study. So we booked about $378,000 related to that. And then we had higher FICA and a higher 403B match number offsetting that just a little. Supplies were below budget, $728,000. This was driven by prosthesis with our lower joint replacement cases, and also our drug costs were almost $500,000 lower than expected. Our insurance, utilities, and other category was $405,000 less than budget. This is a result of about $176,000 of that was a reduction in our reserve for D&O claims as a result of an actuarial report, and then our marketing and software costs drove the rest of that variance. Pro fees for the month were $172,000, and we saw that with medical fees, consulting, and legal costs, and our depreciation was $143,000 lower than budget. So we ended up May with operating income actually almost $3.2 million higher than budget. We'd expected a loss of about $140,000. We ended up with a positive operating bottom line of just over $3 million. Non-operating income for the month came in $750,000 higher than budget at $362,000. And the biggest driver of that for the month was lower interest expense. So we ended up May with a total bottom line from a GASB perspective about $3.9 million higher than the budget at just under $3.4 million. So pretty good month for May. Moving into our Financial Accounting Standards Board presentation, this includes adjustments that the financial markets might make to the previous presentation when they look at it. The first thing we do is we reclassify our revenue bond interest expense out of non-operating expense up into operating expenses. That changes our operating income from a FASB perspective to just under $2.5 million. Then we move down into the non-operating area and we remove our GO interest expense and our property tax revenue that supports that GO debt service, and also our $123,000 unrealized gain on our investments to come up with non-operating income from a FASB perspective, about $41,000 higher than budgeted, just under $500,000. And a total bottom line of $2.979 million from a FASB perspective. Quick look at earnings before interest, taxes, depreciation, and amortization. And this is, again, a representation of the income that the operation and non-operating activities are providing to support our interest expense and also capital expenditures and other program expenditures. We look at our operating expenses before we recognize depreciation, and we end up with EBITDA for the month of about just over $7 million. Then we look at our non-operating area and remove that interest expense, and we end up with non-operating income of just over $2 million. So in total, Washington Hospital's operating and non-operating activities provided about $9.1 million to service that debt and provide funds for capital expenditures and program development. So nice to see that number coming up the last several months. And that's my report for tonight. If there are any questions, I'll be happy to take them.
Any questions from the board members? It's nice to see some breathing room here, Chris.
Yeah, it is. Absolutely.
That's good. Okay, can we go on to our operations report?
All right, thank you. I'm going to present the preliminary operations report for June and to remind the board that this is the last month of our fiscal year. So gross revenue of $186.6 million for June was above the budget by $15 million, or 8.7%, and above June of 2020 by $20.8 million, or 12.5%. If we look back at the pre-COVID-19 12-month average from February 19th, or March of 2019 through February 2020, total gross revenue was $181.7. So overall, in terms of how we've done in June, compares favorably to where we were pre-COVID. So the gross revenue for the current month is 102.6% of pre-COVID-19 average. Our inpatient gross revenue of $111.4 million was above budget by $2.6 million, or 2.4%, and $7.7 million, or 7.5%, above June of 2020. Our outpatient gross revenue of $75.3 million was above budget by $12.4 million, or 19.6 million, and $13 million, or 21%, above June of 2020. I do want to note in June we had 14 COVID-19 discharges, representing 2% of our total discharges. Moving on to our key census statistics, our average length of stay of 5.63 was above the budget of 4.98 by 0.65, or 13.1%. Really resulting from the higher acuity of our admitted patients. Our outpatient observation days were 161, or 91% above budget at 338 days, and our average daily census of 139.5 was below the budget of 141.7 by 2.2, or 1.6%. And I do just want to make sure to note that the average daily census does not include our observation days, so that would be on top of the average daily census. In general, our COVID-19 patients have a higher acuity and average length of stay at 9.6 days. And so this month, the average length of stay for the 14 COVID-19 discharges was 16.5 days, and one of them stayed longer than 141 days. So we had a very long length of stay of that one COVID patient. Of the non-COVID-19 discharges, there were 8 patients with length of stay greater than 31 days, 1 patient at 54, and 4 patients with length of stay of 45, 42, 41, and 40. Still in-house, we do have 4 patients with length of stay over 30 days. So we're continuing to work on that, but it does demonstrate how sick many of our patients are. Moving on to the admissions trends, admissions were below budget by 73, or 8.5%, and admissions for the month were 10, or 1.3% above June of 2020. If you look at the pre-COVID-19 12-month average, it was 906, of which 83 were inpatient joint surgeries that have shifted to outpatient, so normalized it was about 823. So we're a little bit off with that comparison. Moving on to patient days, admissions were below budget by 8.5%, but the length of stay was higher than budget by 13.1%. This resulted in patient days of 4,185. This was below budget by 1.5% or 65. The patient days for the month were 184 or 4.6% above June of 2020. Looking at our surgical trend, we had a good month for surgeries. Total surgeries in June were 405, which were above budget by 37 or 10.1%. If you look at the pre-COVID 12-month average was 386, so above that. Looking at our inpatient surgeries, they were 9 or 5% below budget at 172 and 12 or 6.5% below June of 2020. Our outpatient surgeries were 46 or 24.6% above budget at 233 and 37 or 18.9% above June of 2020. Looking at the breakdown of our surgical activity, our general surgical procedures were above budget by 19 or 10.8% and 8.3% above June of 2020. And looking at the pre-COVID 12-month average was 195, so right on in terms of that. Joint replacement surgeries were above budget by 16 or 10.1% and were 7.4% above June of 2020. The pre-COVID average was 151, so above that. Looking at neurosurgery surgical procedures, they were below budget by 2 or 10% and were 41.9% below June of 2020. And the pre-COVID average was 25. Our cardiac surgical procedures were above budget by 4 or 30.8% and were 183.3% above June of 2020. And the pre-COVID month average was 10, so above that. In terms of cath lab trends, we also had a good month in terms of that. Our cath lab procedures for June were 409, and which were 27 or 7.1% above budget, but 8 or 1.9% below of June of 2020. Just looking at that in terms of cath lab cases for June were 204, which were 17 or 9.1% above the same period last year. And that pre-COVID average was 202. And we will be, moving forward, we'll be also talking more, you'll be seeing it in cases versus procedures. Looking at inpatient cath lab procedures, we're below budget by 29 or 12.4% at 204 and 62 or 23.3% below June of 2020. Our outpatient cath lab procedures were above budget by 56 at 37.6% at 205 and above the prior year by 54 or 35.8%. So saw a shift to an outpatient procedures. Looking at the breakdown of the cath lab procedures, peripheral vascular procedures were below budget by 1 or 0.6% and 29 or 15.6% below the same period last year. Cardiac procedures were above budget by 9 or 6.4% and 8 or 5.6% above June of 2020. Our non-vascular interventional radiology procedures were above budget by 19 or 24.7% and 10 or 11.6% above June of 2020. Then lastly, neurointerventional radiology procedures were basically right on budget at 6 and were higher than June of 2020 by 3. Also, we had a good month with deliveries. As you can see, our deliveries for June were 132, which were above budget by 9 or 7.3%. Looking at our non-emergency outpatient visits, they were 7,984, which were above budget by 949 visits, or 13.5%, and were above June of 2020 by 1,788, or 28.9%. In terms of looking at those areas where we were above budget, lab visits were above budget by 437, or 17.4%. Our respiratory therapy visits were above budget by 168, or 106.3%. Our diabetes education visits were above budget by 100, or 61%, and our outpatient wound visits were above budget by 94, or 28.4%. So really starting to see a lot of our outpatient visits coming back. Looking at our emergency room visits, the trends of visits were 3,881, which were below budget by 202 or 4.9%, but were above the same period last year by 857 or 28.3%. And this number represents about 86% of the pre-COVID-19 level, which is pretty much what we've been consistently seeing over the last few months. So looking at our gross revenue recap, emergency visits were below budget by 4.9%, and RSTU closed earlier in the year, driving emergency room revenue down by $1.4 million or 12.2%. Our cath lab procedures were above budget by 27 or 7.1%. And as noted, there was a shift from inpatient to outpatient resulting in cath lab revenue being pretty much right on budget. Our deliveries were above budget by 9 or 7.3%, driving our birthing center revenue up by $173,000 or 5.6%. Our patient days were below budget by 65, 1.5%, but patient acuity was higher, as we've talked about, resulting in our room and board revenue up by $1.3 million or 4%. Total surgeries were higher than budget by 10.1% and had a favorable procedure mix, driving surgical revenue up by $7.2 million or 21.1%. And then lastly, our outpatient activity drove ancillary services revenue above budget by $7.7 million or 10.1%. Looking at the preliminary payer mix for the month, you can see government-sponsored patient revenue made up 71.8% of total gross revenue. This is higher than budget by 0.4% and higher than prior year by 2.3%. And there was a shift, you can see, from Medi-Cal to Medicare in the month. Our HMO was 3.3% of gross revenue, which is above the budget of 2.6% and higher than prior year of 2.7% of gross revenue. We did have 2 high dollar accounts totaling about $1.7 million that's really driving the majority of that increase. Our PPO was 22.9% of gross revenue, which is below the budget of 24% and lower than the prior year of 25.7% of gross revenue. And then private pay was 2% of gross revenue, which was right on budget and pretty close to the prior year. Moving on to our productivity indicators, you can see our productive FTEs were below budget by 9.9 or 0.8% at 1,257.1. Our non-productive FTEs were above budget by 33.5 or 20% at 200.6. So total FTEs of 1,457.7 were above budget by 23.6, 1.6%. But as you can see, we really had a lot of staff that were taking time off, and we're going to be seeing that. We've had a lot of staff that have not been taking time off, given just with the pandemic, and really trying to give some people some time to be with their families. If you're looking at our productive FTEs per adjusted occupied bed, we're at 5.39, which was lower than the budget of 5.67 or 4.9%. Our total FTEs per adjusted occupied bed of 6.25 were lower than the budget of 6.41 at 2.5%. So overall, it was a good month in terms of our productivity per FTE per AOB. All right, moving on to our outpatient statistics. Whitman's clinic visits were above budget. They had a very good month in June by 506 or 3.4% at 17,162. This was mainly due to higher than budgeted visits in GI and pediatrics. This was 3.2% above the June 2020 visits. Looking at DevCo visits of 2,720, they were below budget by 453. Or 14.3% for the month. And as you can see, this is mainly driven by our Washington Urgent Care. As you know, our clinic has been operating at reduced hours, and it did close as of June 30th, 2021. We are in the process of working on a relationship with another entity to bring other urgent care clinics into this community, and we have put in place the ability for our community to receive urgent care. We have a number that they can call, and we will get them into same-day appointments in some of the nearby clinics that we have so that they can get services close to where they live, right, as the interim solution. You can see that Ohlone College Student Health Center was down in terms of 17 visits. The clinic, basically, the staff are in the process of planning. Ohlone is going to be going into more of a hybrid model for the next academic year, where some students will be on site and others will be virtual, and so we'll feel that we'll be seeing clinic visits coming through the Student Health Center come the fall. Our Radiation Oncology Center treatments were up by 29. As you know, we've implemented our new linear accelerator, and we've been seeing a higher volume there. Washington Outpatient Rehab Center is above budget by 39, and also our Washington Outpatient Surgery Center was above budget by 103. Moving on to the key financial statistics, our days cash on hand, we had a good month, ended at 173 days, an increase of 11 days from last month. This is predominantly due to three areas. First, we have seen an increase in patient collections of 5 days. We did have some federal supplemental program that resulted in about 2 days of additional cash days on hand, and then we had lower average operating expenses, and that equated to about 4 days. I do want to note that in July we do have a revenue bond debt service of about $12.7 million that needs to be paid, and that equates to about 11 days. Our days of gross revenue and accounts receivable were 64, and as you can see, there was $165,609 in charity care applications that were pending or approved in June. So that is the last month of fiscal year 21. Wanted to present that this evening.
Thank you, Kimberly. Any questions from the board members regarding June?
I had a question. I was just curious about what's driving the large numbers of observation days.
And that is a good question. One of the things that we've been really working hard with our case management and nursing and physicians is to ensure that our patients are being placed in the appropriate level of care in a timely manner. And so that is what has been an initiative that we've been working on, and so that is really what's been driving those numbers. I don't know, Chris, if you have anything else?
Yeah, I mean, we're trying to get away from, automatically admitting patients who maybe don't need to be admitted, and the hope is that this is going to reduce denials for those days. They're being careful to make sure that these patients meet criteria for observation, and also taking the time to really evaluate whether they need to be admitted or not. We do on a lot of one-day stays, if they don't meet criteria, the stay gets denied. So we're really working on that with this piece and several other initiatives that are going on. Yep.
Mm-hmm.
So it's a good thing, reflecting better management of that population. Good. Any other questions? Okay, Kimberly, you've got some announcements.
I do. I want to start with our Employee of the Month for July of 2021, and that is Joe Kim. He is the lead cath lab technologist. When Kim first meets patients, they are often in excruciating pain. Joe is proud to be part of a team that offers true relief to those patients. In 1998, after a year as a radiologic technologist, Joe joined the cath lab department. He was able to transition his training and experience to be an integral part of the team. Specializing in vascular imaging, Joe makes sure the surgeons have what they need to perform the procedures that will ensure that the patient has pain relief and in some cases saves lives. Joe describes his coworkers as a quirky bunch who understand that the varying personalities of the interventional radiologists and vascular surgeons require different approaches. Because the intensity level of the procedures can be high, each team member must remain focused at all times. They typically care for 8 to 10 patients a day, sometimes more. Joe Kim is the person everyone can count on, says Christy Holt, and he is quick thinking and is able to use his quiet demeanor to calm patients and elicit confidence from physicians. Joe says he and his coworkers completely embrace the Washington Hospital's patient-first ethic. They do whatever they can to make a patient feel comfortable and cared for. Joe and his wife Stephanie have 2 daughters, ages 11 and 13. When not spending time with family, Joe enjoys his garden, growing tomatoes, boysenberries, and cilantro. Congratulations, Joe, on our July Employee of the Month. Moving on to just a couple of other announcements that I want to give. I do want to just give an update on we are still having our operating our community vaccination clinic, and it is scheduling at this point anybody 12 years of age and older who live or work in the Washington Township Healthcare District. And as of Monday, July 12th, the total number of COVID doses that we have given is 65,188. So I think that is great work, and want to make sure that anybody that needs to get vaccine can do so, and they can get the information through our website. Moving on to a couple of the outreach events that we've done. On Wednesday, June 16th, Sherry Harrington, a registered respiratory care practitioner, presented Breathe Easier with Pulmonary Rehab on Facebook Live and YouTube. We had 42 community members participated, and since that time, 151 additional people have accessed the presentation on the social media channels. Then on Wednesday, June 30th at 3:30, Anna Mazai, a registered dietitian, provided a topic of fun, fresh summer cooking demonstration on Facebook Live and YouTube. She had 24 members participated in the event, and since that time, 169 additional people accessed the presentation on one of our social media channels. We do have 2 that are coming up. The first is July 15th, which is tomorrow, from 7 to 8:30 p.m. As part of the Women Empowering Women Support Group series, Dr. Victoria Leapart, our gynecologist, and Cindy Lee, Wellness Center yoga instructor, will present Staying Fit this summer on Zoom. And then on August 3rd at 6:30 p.m., Dr. Sarah Wortman, our vascular surgeon, will present Chronic Venous Disease Causes, Symptoms, and Treatment on Facebook Live and YouTube. Last, also, I do want to talk just briefly about, the City of Fremont, we are participating in their summer concert series, which the first one is kicking off tomorrow evening with the Sun Kings, a Beatles tribute band, and we will be offering free COVID-19 vaccinations for those people who have not been vaccinated. So just anybody who will be attending, and I know Dr. Bernard Sturt is going to be there representing the healthcare district, and so also we will have members of our cardiology team there to answer any questions and talk about all the cardiology services. But wanted to make sure that everybody knew that we would be giving out free vaccinations tomorrow at the summer concert series. So those are my announcements this evening.
Well, great. Thank you, Kimberly. So we got rock and roll and vaccines too with Chris Hart.
That's right.
Very good. What a way to go. Thank you. Okay, do we have need for a closed session, Kimberly?
We do not.
Very good. Are there any questions or concerns that the board members would like to raise at this point in time? Good. There being none, and there being no further business before this board, this meeting is now adjourned. Have a great week. Take care, and encourage all those who haven't been vaccinated to go to the concert and get vaccinated.
That's right.
Okay, Bernie. Okay, Bernie, get everybody vaccinated that's there that's not been vaccinated.
I'll do my best.
Okay.
Great.
Okay, good night.
Good night.
Night.
Good night.
Hey, everyone.